So I'm very grateful for receiving this task of talking about novel aspects of PTDM. Um, it's kind of challenging because it sort of predicts that there are several novel aspects. I will do my best, and then we can discuss the issues afterwards. So first, my disclosures that you can see here. And then the definition that we still use for the diagnosis of post-transplant diabetes mellitus. We went away from the definition new onset diabetes several years ago, as many of you know, because we are not always quite confident or sure whether the patient had a latent or mild diabetes prior to transplantation. So this is actually more pointing to the time of diagnosis rather than to the time of onset of diabetes. We still use the OGTT as the gold standard to detect diabetes in these patients, although there are several research reports saying that HbA1c will serve pretty well, uh, provided that you do the diagnosis later on after the transplantation, meaning sort of 1 year or later after 1 year. So this might be a thing to revise. I'll start off with an old story before we go to the new issues. The old story is that not only post-transplant diabetes mellitus, but also pre-diabetes or impaired glucose tolerance, as in this case, is a true risk for mortality. That makes even our surgeons interested in PTDM because they know that they lose the patients once the transplanted patient runs into diabetes. This is an old follow-up study of 1,200 patients from our institution, published almost 10 years ago. We were not able to dissect at that time to what extent this was cardiovascular death or cancer death or whatever, but you can appreciate that PTDM and impaired glucose tolerance, those patients run a pretty increased risk for death compared to those with milder prediabetes, impaired fasting glucose, or normal glycemia. Later on, just a couple of years ago, Esteban Perini and his group in Spain published these important results, saying that patients with prediabetes and PTDM also run a cardiovascular risk for cardiovascular events. So prediabetes was in this case determined as IFG or IGT. We know that this is also the case in all the transplanted group, like those being heart transplant, those having liver transplants, and those having lung transplantation. So it's the same story of PTDM across the different kind of transplantations. As we could see in the kidney transplanted groups, this is the figure that I showed you just a few seconds ago. Why is it that we do have increased risk of PTDM after transplantation? Now, this is an old figure that we have shown several times. And I don't want to go into detail here. These are the non-modifiable risk factors. These are the potentially modifiable risk factors. And these are the modifiable risk factors. We have placed a lot of focus on the immunosuppression, which is with particular emphasis on steroids, calcineurin inhibitors, but maybe tacrolimus is judged as the most diabetogenic of those two drugs. But I have to emphasize pretty much in those at risk for diabetes, those with metabolic syndrome, insulin resistance, high triglycerides, or high free fatty acids. mTOR inhibitors are also diabetogenic because both they impair the beta cell function, they also create sort of an insulin resistance. But we have also these classical the risk factors for developing diabetes. And we should appreciate, according to recent results, not so recent, this was published in 2015, that central visceral fat is actually a risk factor by itself in renal transplant patients for developing post-transplant diabetes. This is assessed 8 weeks and 1 year after transplantation, the same results. While BMI body mass index does not seem to have the same prediction. So it seems to be something about the visceral fat that turns the patient into a risk of diabetes or impaired glucose tolerance. These assessments were done among 150 kidney transplant recipients. The visceral fat was assessed by a DEXA technique, a modified DEXA measurement. And this has also been confirmed later on in other studies. Why should that be? Well, the visceral fat is sort of the bad guy. There was several years ago in the diabetology about Elo Ferranini and his group, they published that of all the glucose clamp assessed insulin resistant patients that they measured, 1,000 persons around in Europe, one third of them who were obese did not have insulin resistance as assessed by a glucose clamp technique. And these were the guys who did not have abdominal obesity. Those were the guys who had normal fat deposits outside the abdomen. Those with abdominal fat tend to create detrimental substrates that may actually increase insulin resistance and maybe also impair beta cell function. For instance, inflammatory factors. This is a recent report from Torbjörn Heldahl, where he actually could show that among some 800 patients that several of these inflammatory markers that also may originate from abdominal fat seems to have a risk assessment, a risk impact for developing PTDM after transplantation. Later on, he has also developed trajectories of these risk factors, these inflammatory factors, showing that they also predict a death among these patients. That manuscript is not yet published. It's in submission right now, but the results are going to be presented at the ESOT in a couple of months from now. So trajectories of these inflammatory factors seems to actually predict not only PTDM, but also patient death in the long run. At the EDTA meeting just recently, there was also an abstract presented orally from Groningen by Sarah Oskay, saying that the use of diuretics may actually be a risk for post-transplant diabetes mellitus development. And that was actually reported both for thiazides and also for loop diuretics. And her group did also measure diuretic metabolites in the urine and could also show that the metabolites in the urine also associated with an increased risk for development of post-transplantation diabetes mellitus. The causes can be speculated upon. It could have to do with potassium, magnesium, whatever, but the observation is there. And I also like to mention this important study from Morten Bruce Jørgensen and his group, Mats Hornum in Denmark. Not many patients included in this study, 9 patients, but it's a very elegant study with a complex technique using tracer monitoring of endogenous glucose production during hyperglycemic, euglycemic hyperinsulinemic clamp. And actually, the tricky part of such a study is to obtain in the circulation insulin levels that are not too high, that it totally would suppress the endogenous glucose production from the liver. You need to hit the point in concentration of insulin in the circulation at actually half maximally suppress the endogenous production. And you can see that they pretty much did that. These are the same 9 patients studied before transplantation, after transplantation, rate of appearance. This is actually the endogenous production of glucose, and the rate of disappearance, which actually is the sum of endogenous glucose production and the glucose being infused. You can see that all in all, glucose infusion rates was highest before transplantation. And in controls, excuse me, these are controlled persons, non-controlled persons, and these are the patients being studied before transplantations and after transplantation. So actually the insulin resistance is higher after transplantation because they need less glucose to be infused. and the endogenous glucose production, this column, is higher in the patients after transplantation than before transplantation, which is shown in the blue column. These are the controls. When I go back to this as an important observation in terms of what should you treat these patients with later on. This figure was shown yesterday, and I like the figure. I tend to show it in many of my presentations. This is also the Spanish study by the Spanish multicenter group from Esteban Paridi, doing repeated oral glucose tolerance tests in patients after transplantation. And it shows that the highest incidence of PTDM comes early after transplantation within 3 months. These are new cases later on. And the accumulated incidence shows a biphasic curve showing that the highest is here in the early phase, then the weaning period, and then a new increase some 2 or 3 years later on. And it could very well be, as it was discussed among you yesterday, that this sort of reflects the acute pharmaceutical burden of immunosuppressive therapy, which sort of tapers in doses and things go better before more conventional risk factors take over later on. So what about the early phase, the drugs that we use? Well, one has thought that steroid withdrawal would do the thing, that would sort of decrease the PTDM incidence. Well, it doesn't really look like that. This is one out of several randomized controlled studies. This one is from the States, where they withdrew actually prednisolone 7 days after transplantation. And even if there is a numerical decrease in the occurrence of HbA1c above 6.5, HbA1c above 6, use of insulin, and diagnosis of diabetes according to ADA criteria, which is pretty much similar between the two groups, there's no statistical difference here. So the maintenance dose of prednisone was pretty much 5 milligrams a day, and it doesn't seem to be any big difference in terms of PTDM development if you use 5 milligrams of prednisone or nothing. The Australian group by Yates and co-workers gave us probably a good message, which sort of we try to include in our practice. We haven't made it completely yet. But if you use high doses of prednisone in this kidney transplanted patients, like 20 milligrams a day, splitting the dose in 10 milligrams morning and evening makes a more even glucose curve during the day. This is subcutaneous glucose measurement assessments. This is the two curves with 20 milligrams in the morning, 10 milligrams morning, 10 milligrams evening, and these are the two curves superimposed on each other. You can see that there is a glycemic improvement in dividing the dose, provided you're using high doses of prednisolone. And then finally, my final slide about the drugs, the immunosuppressive drugs. The switch from tacrolimus to cyclosporin may be beneficial in some patients with PTDM. This is the Austrian-German study, 84 patients who were included 6 months after renal transplantation, all on tacrolimus. Half of them switched to cyclosporin, and they were assessed with PTDM 1 year after the switch. And you can see that those who used cyclosporin had a greater chance of being free of PTDM 1 year after switch. The result was most impressive in those who did not use glucose lowering therapy, more modest in those on oral agents and insulin, but these are small numbers, as you can see. But this is sort of convincing. It's the largest study that we have till now on switch and these medications. And then we are still waiting for the large trial, which also from Manfred Hecking and co-workers in Austria. They published this pilot study almost 10 years ago. Now they have finished a larger multicenter trial, which is in the publication phase. But what they showed in this pilot trial was that if you used intensive glucose therapy for the first few weeks after transplantation and people were put on insulin compared to a control group that did use oral glucose lowering drugs or nothing, you can see here that those who were on insulin alone were those who were actually in the intensive treatment. Those who were in the control group did either use nothing or maybe a few used some oral glucose lowering drugs. After 1 year, insulin was withdrawn and there was no persons in the intensive glucose control group that 1 year afterwards were on any insulin therapy or glucose therapy. They did not have PTDM. 8 patients out of 25 had still PTDM. Now, we don't know if this holds true, but there is a large study that is published in these days. We have to wait to see the results. I borrowed this picture from Stephen Kahn, who actually some years ago gave a lesson of all the development in the glucose-lowering drugs that we are using in type 2 diabetes. I used to say that in my view, we could look at this with interest, but these cannot be directly translated to the treatment of PTDM because we have to know about side effects in this particular patients group, and we need also to know about the interaction to the immunosuppressive agents that we're using. Anyway, in both cases, type 2 diabetes and PTDM, we need to individualize the treatment and avoid adverse effects, at least in those rather fragile patients that we have that are being kidney transplanted. We want to avoid hypoglycemic events in patients with high cardiovascular risk. And that's why we tend not to use sulfonylurea treatment or avoid insulin if it's not very necessary. We have to wait for the results from Manfred Hacking's group, but we try to stay away from things that could make the patients hypoglycemic. So the question, of course, is what about the two new classes that you have been discussing already in the previous session, the GLP-1 receptor agonists and the SGLT2 inhibitors? To tell you the truth, we did a small study several years ago, and this is a collaborative study with Copenhagen, where we did a hypoglycemic clamp study in patients, renal transplanted patients with and without diabetes, post-transplant diabetes. 12 patients in each group, not very many, but the results were rather convincing. I don't want to go into detail. I will spare you. We will save time by that. But just saying, if we elevated the plasma glucose levels 10 millimoles from the baseline levels, we could see that the PTDM patients both had an impaired insulin release and an elevated glucagon release. So they did have hyperglucagonemia, as you can see in type 2 diabetes. Once we gave them a continuous GLP-1 infusion compared to saline placebo, you can see that GLP-1 both increased the insulin response and decreased the glucagon profile. So these patients behave just the same way with GLP-1 and incretin effects that you would expect to see in a type 2 diabetic person, which sort of jives with the findings of Martin Booth Jørgensen showing that these patients also have an increased endogenous glucose release from the liver, which probably is under the influence of glucagon, among other things. So there is a rationale for using GLP-1 receptor agonists in these patients. However, the reports are just case reports so far. We don't have really good clinical trials. We are waiting for that, and these are badly needed, but we do not have them yet. I just tried to review some of these case reports, and I came across these are uncontrolled, just saying that the treatment seems to be safe, it is efficient, but these are short-term studies, only weeks, maybe up to 1 year. Altogether, I could find that these sort of case reports reported from 124 kidney transplant recipients, not many. So what about the SGLT2 inhibitors? We heard about that in the previous lecture. This could actually be of benefit to the kidney, at least in native kidneys. You heard about the CKD-DAPA study and I just want to mention that we have a prevailing problem in kidney transplant recipients. We have reduced the rejection rate, the kidney rejection rate, from maybe 30% in our hospital 15 years ago to nowadays 10%. So we had only had 10% rejection of transplanted kidneys during the first 3 months. Still, we see the same as this report from 3 continents, that the half-life of the transplanted kidneys are still only between 12 and 17 years. So after 12 and 17 years, there is a graft loss in half of the patients. This is a major problem, with the need for retransplantation later on. Could it be that any kidney prevailing saving therapy could change these curves? It is tempting to think so, that maybe some SGLT2 therapy could affect this, but we don't know that at all. But people are trying to speculate now. This is just a recent paper from the Secretion saying that we have to think outside the box to maintain survival of kidney grafts. We should think outside the box of immunosuppression, whatever. We should also think of hypertension, electrolytes, magnesium, potassium, and also maybe SGLT2 inhibitors, but we don't have these results either. The first case report on SGLT2 inhibitors in kidney transplant recipient, that was with canagliflozin, published in 2017. This is from the Toronto group in Canada. In 2019, actually accepted in 18, published in 19, the Austrian group gave a case report on empagliflozin, and we did a small randomized trial of empagliflozin versus placebo among 44 patients with PTDM assessed more than 1 year after transplantation. So this is probably the only randomized controlled study, placebo-controlled study so far, but it's a very small short-term study, only for 24 weeks. There was a review on use of SGLT2 inhibitors in kidney transplant recipients last fall, and it concluded that there was available 8 studies with 132 patients in total. So pretty much in the same ballpark as GLP-1 receptor agonist studies. Let me just briefly go back to the small randomized controlled trial that we performed in our 44 patients with PTDM. This was not actually supported by the pharmaceutical company. We bought the tablets, we coated them and made similar placebo pills. So this was a placebo-controlled study. And some people were sort of uh, disappointed that the reduction in HbA1c was only 0.2 percent points. There was an increase in the control group of 0.3 percent points in HbA1c. But you have to recall that this was sort of a safety study, also some efficacy. The baseline HbA1c in this study was as low as 7%. So there was not much to obtain, I would say, by giving a glucose-lowering drug to a baseline HbA1c on 7%. Some of the case reports I showed you just before had a baseline HbA1c of 8, and there you have the same lowering of glucose as you see in other patients with type 2 diabetes. These are the baseline glucose lowering levels in the treatment group versus placebo, and this is a 2-hour glucose, the change from baseline. So you have a lowering of both the 2-hour glucose and the baseline glucose during the oral glucose tolerance test. The interesting part that we did, which probably also tells you the limitation of these drugs as glucose lowering drugs in type 2 in PTDM patients, it deeply depends on the GFR. In this case, we did use only eGFR, not measured GFR, with all the limitations that Esteban would emphasize. But still, if you had, this is 24-hour glucose excretion in the urine, and you can see that with empagliflozin, you have a pretty high glucose excretion over 24 hours, but once the GFR goes down to 50, there's not much difference in glucose excretion compared to placebo. And you can see this corresponds very well with the effect on HbA1c, that HbA1c lowering is virtually absent once GFR goes down to 50. Now, the point is actually, as Fredrik talked about just in the other talk, that the kidney protective effect is not dependent on the glucose lowering. So maybe, I'm just saying maybe, we could be so lucky as to see this effect also in kidney transplanted patients. This is just a secondary endpoint in the EMPEROR reduced study with heart failure patients. You see the initial drop, the dip in GFR, then the stabilization, which is sort of beneficial in the long run compared to placebo. A subgroup actually withdrew the drug, and you can see that you get your GFR bonus back again. This is actually payback of the early dip. Once you withdraw the drug, you see that the GFR comes up again, while the placebo is still down there. And the difference of slope in this case between the two treatment groups, the difference in slope between empagliflozin treated group and the placebo treated group was actually 1.73 mLs per minute per body surface per year. Now, this estimate has been done in all the studies that you just heard about, and it's sort of in the ballpark between 1 and 2.5 in difference. What that would mean in a transplanted kidney, we don't know. We simply don't know, and the pharmaceutical companies are sort of reluctant to do this study so far, but we are still trying to convince them. There are special things with this kidney here, the transplanted kidney, that may not be present in the native kidneys where we have seen the effects of the SGLT2 inhibitor. These kidneys are under the influence of tacrolimus or cyclosporin. These are calcineurin inhibitors that tend to contract the afferent arteriole, which is sort of in the same thing as the tubular glomerular feedback that the SGLT2 inhibitor would do. These are kidneys that are denervated by this definition. They do not have innervation as far as we know. So these are not innervated kidneys as the native kidneys. There are several aspects to be sort of concerned about. What I can say about the SGLT2 inhibitor case controls, case report studies, and also our randomized small study for 24 weeks, there were no signal of increased urinary tract infections. There were no signals of mycotic infection more than in the control group, and there were no cases of ketoacidosis. So according to the usual side effects, the risk, I think, with these drugs is not very high in this population, but the effect is still not documented. So to conclude, PTDM and even post-transplant impaired glucose tolerance or impaired fast glucose for that cases are conditions which predispose to cardiovascular disease and death. This could be in mind for future treatment of the patients, also with the new glucose lowering drugs. Lower doses of corticosteroids and switch from tacrolimus may improve the glycemic burden, reduce it, but recommendations of hypoglycemic agents should be based on studies in this particular patient group, not studies in type 2 diabetes. Glucose lowering treatment should be tailored to avoid untoward effects, for instance, hypoglycemic events. And the role of SGLT2 inhibitors and GLP-1 receptor agonists for both cardioprotection and renal protection needs to be further studied in renal transplant recipients, hopefully in larger randomized controlled trials with solid endpoints. We desperately need that in the situation we are right now. Till then, we have to, as in all other patients, favor the personal centralized approach. We have personalized medicine. We are not treating a diagnosis. We are not treating the gray mass around them. We are treating the individual. So I'll end that, and thank you for listening. Thank you very much.
All right, thank you very much, Trond. It was very interesting, and yeah, Frederik.
Thank you, Trond. I was wondering, in your very nice randomized trial with SGLT2 inhibition, did you measure serum levels of immunosuppressants? I mean, were they affected in any way by SGLT2 inhibition, or any signs that would worry you in a sort of a long-term safety perspective?
No, we measured, yes. We could not see any influence on the TREF concentrations, neither of tacrolimus, which was majorly used, or on mycophenolate CellCept. So everything was actually the way it should be during study. No change and no difference between the placebo group and the PTDM group.
Thank you very much, Trond, for the talk. I have two questions. Is it possible that we can identify the perfect match patient for both a GLP-1 agonist and the SGLT2 inhibitor treatment in order to narrow in those patients that actually benefit for having the treatment in terms of GLP-1 effects of decreasing obesity or BMI and lowering the use of insulin? And the second one, do you see any potential risks in providing these patients with a GLP-1 agonist in terms of increased risk of cancer, pancreatitis, rejections?
Thank you, Mats. I reckon it was you who asked. I just hear your voice. I can't see you, but we have been using GLP-1 receptor agonists in particular patients, and know you have too. The major gateway to this patient for a GLP-1 receptor agonist will be obesity, a need for body weight reduction, and also diabetes post-transplant or type 2 diabetes, whatever. The case reports that I'm sure you are aware of too have used GLP-1 receptor agonists without any observed side effects, no problems with immunosuppression doses or TREF levels, and no signs of pancreatitis, thyroid effects, whatever. So by the few observations that we have till now and the general practice, they seem to work okay. I even used GLP-1 receptor agonists in some of our pancreas transplanted patients who have partial pancreas failure, partial failure of the pancreas graft. And in those patients, the GLP-1 receptor agonist works very nicely to relieve the patients from the use of insulin, just working very nicely with a reasonable amount of C-peptide with addition of a GLP-1 receptor agonist. And also in pancreas transplanted patients, we have no problems with interactions with drugs or whatever, and no side effects. So I think that should work. As for SGLT2 inhibitors, we use SGLT2 inhibitors in patients who primarily today need a glucose lower, an add-on glucose lowering therapy. We don't use SGLT2 inhibitors in patients who can use some of the other well-proven drugs in PTDM, like DPP4 inhibitors, whatever, but we use it as an add-on drug so far. We do not use SGLT2 inhibitors as renal protective drugs because we don't have that documentation yet.
Hi, Trond. I'm Esteban. Nice to see you. Thank you very much for this overview, full of open questions, and we still need to answer. Just, I wanted to, because you were reviewing the topic, we found that your studies and other studies, Mats and everyone, that is related to cardiovascular disease and prediabetes is related to cardiovascular events, infections, so on. But in the general population, diabetes and prediabetes and metabolic syndrome are related to cancer. And we have a large amount of cancer in renal transplant patients. Do you have any information about that or any comment? Because I think it's something we need to study.
Yeah, you're right. We have not done those particular studies. We know that we do have cancer, a lot of cancer in our patients. Whether that has been related to PTDM or IGT in the renal transplant patient groups, I must admit this, we do not. I don't think we have studied that in full range yet. So we should probably take a look at that as well. So it's a good point, Esteban.
All right, I think the time is unfortunately up, so it was very interesting, and thank you for your time, Trond. So we'll move to the next speaker.